How is everybody doing? And welcome back for another Strength Chat episode. Today, I've got a very special guest for you all. Today, I'm joined by a doctor of physical therapy, a strength and conditioning coach. He writes, he's a researcher. Today, I'm joined by the one and only Dr. Merrick Lincoln. How are you doing?
Great. Thank you, Coach. Thanks so much for having me. Man, your podcast is a who's who of strength and conditioning. What other physical therapists have you had on?
Quite a few really. So I've spoken with Dan Pope, which was really good. Spoken with Professor Stuart McGill, which was really good. I know that was about a little bit more lower back. But yeah, I always feel really lucky when people respond to me, and really appreciate when people take the time to jump on, much like yourself. And how are you? What's been happening in your world recently?
I'm honored to be invited. Just, appreciate it. Thanks, Coach. So like you mentioned, it was a great intro. I'm a physical therapist by training, and I started my career as a clinician. I found my way into academia. So my current full-time career is associate professor. I work in the exercise science and rehabilitation medicine programs it's a mid-sized university called Saginaw Valley State. It's in Michigan, United States of America. You'd be forgiven for having not heard of it. I grew up, in and around the Detroit area. And that was that's only an hour and a half away. And I had never heard of Saginaw Valley State, but we're an up and coming university and trying to make a name for ourselves in pre-professional education. That is, I'm sending a lot of students off to doctorate of physical therapy programs, athletic training programs, doctor of chiropractic programs, medical school, but also in the strength and conditioning front, trying to establish a strong program for up and coming strength and conditioning professionals.
Yeah, nice. And with that, because the little bit I know about where gyms are and where the US. I've only ever been to New York and I've only ever been to Florida, so two very different places. But I know, in a small area there can be quite a lot of gyms, quite a lot of sports teams, especially in terms of like college teams. What's kind of the catchment area around you? Is there quite a lot, or is it a little bit further afield?
So it's an interesting place. If you envision the state of Michigan, it's that area that's surrounded by Great Lakes or inland seas. So it's very identifiable on the map, and it's shaped like a mitten, right? So we're right where the thumb meets the hand of the mitten. So we call it the Great Lakes Bay region. Very, very different from the San Francisco Bay region, which, that's tech billionaires. Very nice weather. We get nice weather half the year. The summer, the fall, the spring actually are quite nice, but we just got a load of snow last night. But in the Great Lakes Bay region, we have some industry. So one of the largest chemical companies in the world is based here. Strong healthcare presence. Mid-sized universities. There are no large universities in this immediate area. And then the larger sports teams are around Detroit, right? That's the biggest city in Michigan. So it's an opportunity in a sense, where a clinician like myself might have the opportunity to work with a team or a minor league team, whereas the professional teams often have employed rehabilitation professionals and employed strength and conditioning coaches, whereas we could potentially get involved in a more of a as a consultant or
Yeah.
in addition to our day-to-day work. So there are opportunities as well, but it's a unique place, and it's actually it is the most affordable university in our state. So we draw a lot of students who might be first-generation college students and backgrounds like my own, very blue collar. And I think it's our job as professors, as instructors, as coaches and role models, to show, what can be done if you take these steps that aren't always easy, go through these steps of education, certification, get the experience, and ultimately what kind of career can come of that. So I'm always happy to jump on talks like this, write in the fitness realm, publish in the scholarly literature, kind of spread myself around like that, just to kind of provide an example of what can be done with an exercise science, strength and conditioning, or clinical background.
Yeah, absolutely. It's interesting you said there about sort of the consultancy side of things. A guy that I worked with, well, a friend, should I say, worked with for a very, very long time. We both started at the same time. He's now more of a consultancy role now. So his specialist area is sprinting and working with athletes. So he's worked with people from ultimate frisbee all the way up to the Premiership in rugby with players. So I think sometimes why I wanted to touch on that is when we speak about strength conditioning, people think that you always need to be full time with a team, whereas actually sometimes there can be different avenues that you can go down depending on the area that you're in or the sport that you work with or whatever it may be. You've touched on a couple of bits there in terms of the fitness side of things and the research side of things. But for everyone listening who might not know your background, how you got into training, how you got into research to get to the point, where you are now, just want to give a little bit of a background to yourself.
Yeah, so athletically, I started as an endurance athlete. So, out of college as a pre-medicine student, I got into running marathons, ultra marathons,
Yeah.
half iron triathlons, and I was doing all these things at the same time and suffering overuse injuries. And while I don't have the classic story of I went to physical therapy, I met a physical therapist and decided that's what I want to do with my life. I did meet some physical therapists who seemed to know kind of secrets. It seemed to me they knew secrets of rehabilitating these injuries, and I wanted those secrets. I wanted to know those secrets. So course correct, I didn't go to medical school. I went to earn a doctorate of physical therapy. Coming out of school, I'd always kind of enjoyed reading research in biomechanics and making connections in the gym. So my entry to academia came from those two areas. Guy at the gym who worked for Saginaw Valley State University knew they were hiring, needed a professor who could teach biomechanics. So that's where I started. And ultimately, it led to a full-time position. And here I am doing some clinical practice, a lot of teaching, some research, and then also, the fitness writing side of things. I have over 50, mostly long format fitness articles that I've written in the last couple of years. Unfortunately, that medium it may be a dying breed here. So that's why I'm so happy to be on something like this. This podcast is I consider it in the same way. It's a long format. We get to have a discussion, get into the details. In a world of vertical videos and 30-second sound bites, it's rare to.
Yeah, absolutely. This might be. I think I said in the email when we set up this, there might be a few tangents in there, but I do think so. Basically, we have younger coaches that have come in, maybe it's their first job as a trainer, and they spend some time working with me, training just to develop experience, the softer skills of coaching, but also just increase their knowledge. And I think reading articles, reading journals, or at least trying to have a look at them, and listening to podcasts, and like what you say, the longer form content is really helpful. I think sometimes I always remember we had a chat with one trainer who came in, and he just listed a load of Instagram handles, which was pretty sad to hear, because I think that's become the all conquering, all seeing eye of everything. Whereas sometimes you're not going to get as much information or as much knowledge out of a 30-second clip. Don't get me wrong. I've shared 30-second clips. I think everyone does now. But yeah, I think actually digging a little bit deeper, having discussions, that's the whole reason why I set this podcast up. But also, reading other things is a really useful tool. Just from what you've said there, obviously you've got a couple of hats there, in terms of what you do. How do you find balancing that and switching between sort of the research side of things to then writing articles to then teaching, more so from my side of you, obviously switching from my role is kind of changing from being having a full client list coaching on the gym floor to now coaching other coaches and trying to improve them. And sometimes I do struggle switching roles on there because I'm always thinking from a coach point of view rather than a coach of a coach, if that makes sense. How do you find switching hats?
It's the way I view these things is they're all so closely related. We're working with the same physiology, and my biases, I approach my clinical practice very similar to, how a strength coach might approach their position. And I'm teaching strength and conditioning coursework and biomechanics and exam and diagnosis coursework. So all of these things, they reinforce each other. And my writing and my research is all centered down this line of applied biomechanics and strength and conditioning, exercise technique. So they reinforce each other in a sense. There are different expectations. I sit in an office at the university when I'm not in front of a classroom. In the physical therapy clinic, I'm in, it's like a small gym environment. So it, in a sense, I don't think they have to be mutually exclusive. And I see more and more, I'm opening my eyes to it. There are more professionals who are doing multiple things. You don't have to limit yourself to just one. Just like you mentioned about the consultant friend you had. It may not be his or her full-time occupation, but being a specialist in sprinting, put that knowledge to work, on the side of your day-to-day or 9 to 5.
Yeah, absolutely. So had a little bit of a background, a little bit of a tangent there. I did say sometimes there would be a tangent, but obviously I sent over some of the topics in mind to go through today. And the first question is, and you kind of touched on it being, an endurance runner, picking up niggles and injuries, and you've probably worked with, and seen people just wanting to push through pain and just wanting to keep going. I just wanted to touch on, what is the definition of a pain threshold? What is it when we're talking about that? And does that differ between people? And is it also different when we're talking about athletes?
Yeah. So the scariest thing, another small tangent here. The scariest thing physical therapist hears is when their client comes in, the first thing they say is, well, I have a high pain threshold. and it hurts this much, and you wouldn't believe how common that is. That's it's not a red flag. It's something though. It kind of hints as to this individual's mindset around their pain, and kind of the work we have cut out for us when we're helping to manage that client's case. So I guess we can start by defining pain. A common definition of pain, it's an unpleasant sensory experience associated with or resembling the association with actual or potential tissue damage. Yeah. So that's kind of an interesting definition, isn't it? Yeah. It's an unpleasant sensory experience, and it's associated with potential or actual tissue damage or resembling that association. So it's kind of nebulous in a sense. And what that definition hints at, I think, is that all individuals in pain aren't necessarily tearing down or breaking down their body. It's an experience, and it does belong to the individual that's experiencing it. So that pain experience can be kind of broken down into two key elements here. You have the intensity of the pain, how bad is it? And the pain affect, so how it's affecting their readiness to perform. So if you have an athlete, how does this experience of pain modifying their ability to perform in the gym, on the field, on the court? So looking at that, you'll find individuals with varying intensities of pain, but also experiencing that pain in very different ways. It's affecting their lives in very different ways. So I think the first thing to mention is that because it is an experience that belongs to the individual, that individual has every right and probably should be encouraged to have that pain addressed by someone who's trained in examination and diagnosis. So someone's in pain, they should have the opportunity to get checked out. And that might comfort the individual having a, if it comes to a diagnosis maybe, or just get checked out and maybe get some reassurance from a medical professional of some sort. So I'd like to start there. I don't want to disregard the pain and say, all right, this individual should just work through it. No, we have to check it out. And I think Dan Pope, I checked out that episode. Dr. Dan Pope did a great job of explaining how the medical professional screening for red flags, issues that might be not related to the musculoskeletal system, constitutional in nature, things like that. The medical professional will also screen for high risk injury. So that is injuries that may have a high risk of poor healing. So I'm thinking about stress fractures, stress reactions in a lot of the bones of the foot, around the ankle, on the tension side of the neck of the femur, some of the bones of the wrist, for example. If you have a stress fracture or stress reaction in those locations, those are considered to be high risk, and we might not be as inclined to encourage an athlete to work through really any pain at all if they present with a diagnosis like that. But if we focus on the kind of the more common presentation of musculoskeletal or musculotendinous injuries that are not high risk, we aren't fearing for that tissue's ability to heal, and we aren't fearing for that tissue's health. There may or may not be an injury there, and our definition of pain suggests that there may be actual tissue damage or potentially no actual tissue damage. But once we've been screened, evaluated, and we see that this is not something outside of the scope of musculoskeletal injury or a high-risk musculoskeletal injury, then we might proceed with something called a pain monitoring model. And I know you and Dan Pope talked about this a bit. I've been talking about it lately. I have a lot of respect for Dr. Pope. Actually, early in my career, I listened to a lot of episodes of his Fitness Pain Free podcast. So, learning from these long format platforms. So I think he did a great job of explaining this pain monitoring model that's been used for a variety of diagnoses at this point. It's first was described for use of patellofemoral pain. So that's kind of anterior knee pain. Then a lot more of the research surrounds Achilles tendon pain or heel pain related to the Achilles tendon. We have studies suggesting its use for tennis elbow, for rotator cuff related pain, for patellar tendinopathy, a tendon problem of the quadriceps tendon, and acute hamstring injury. Actually, it was an interesting one. And this research suggests that we don't necessarily have to stop in the face of pain, particularly if that pain is well controlled or low risk. And that pain monitoring model, typically, if you envision a 0 through 10 scale, so a visual analog scale, 0 being no pain at all, and 10 being extreme pain or the worst pain you can imagine. And we have to be kind of disciplined about how we anchor those extremes, because if we anchor them in different ways, people might give us different numbers. So we typically describe the beginning of the scale, the 0 point and the 10, and then don't really try to describe or define the numbers in between. So we ask the athlete or the individual to rate their pain between 0 and 10. And typically 0, 1, 2, or 3 is considered low risk pain for a musculoskeletal injury, a low risk musculoskeletal injury. And a 4 and a 5, that's kind of a proceed with caution. And then above a 5, so you're 6, 7, 8, 9, and 10, typically that's considered high risk. And now these pain scales don't have to be used exactly like that. In fact, that study, Hickey et al., I believe it was 2020, used a threshold of 4 as the cutoff between moderate risk and high risk. So because those individuals in that study had just recently experienced their hamstring injury, they decided to consider 5 out of 10 as being high risk pain. There was another one on shin splints, another study on shin splints that used a pain monitoring model and also considered a 5 to be high risk. So we're not set in stone of using these values, but it's just a general guideline. Now, an athlete might have trouble defining their pain within that range. And I think that is something maybe we can guide our athletes with. And a couple of questions I like to ask the athlete or the client in front of me is, do you feel in control? So this is kind of getting at that pain experience. Do you feel in control of your pain? So if an athlete or an individual feels like they're still in control, that tells me that their pain is likely lower risk, um, relatively well controlled. And then I also ask, does this pain you're experiencing make you feel like you want to stop the activity?
Yeah.
And that's kind of respecting their autonomy, but also hints at the pain experience. Is this pain so severe that they're not wanting to train, not wanting to compete anymore? And that should be respected. So we can help our athletes kind of rate the pain on this pain monitoring model, but we shouldn't endeavor to define each and every one of those numbers. That actually might ruin the validity of that scale.
Yeah. Do you think what kind of went through my head there is having it is just setting the parameters so the athletes can work in, because I think, and we can touch on this a little bit more of that sort of mindsets versus actual maybe tissue damage. From the definition that you mentioned there could be a few different things. The athlete might have had previous injuries in the past, how close the injury was, or the pain. Can you use that as a parameter to change those so you can control maybe how much they can control the exercise, if that makes sense, and how much they push the exercise?
So I think I understand the question. We're approaching this in a way of, we don't necessarily know if there's actual tissue damage. And for example, if we take tendon problems, tendinopathy, or tendon and disrepair, if we look at Cook and Purdam's tendon continuum model, essentially describing the range or the continuum from a healthy tendon to a tendon in complete disrepair. The stage along that continuum where athletes tend to experience pain is a reactive tendinopathy. And in a reactive tendinopathy, there may be very little evidence of actual tissue damage in the clinical sense, where you may not be able to see swelling. You may not be able to feel increased tissue temperature. It would take very sophisticated imaging to clue us in to whether or not this individual is experiencing a reactive tendinopathy. We have to use the clinical suggestions that the athlete brings us. So maybe there was a period where the athlete trained less, and then there was a spike in training load. That might clue us into, this could be a reactive tendinopathy. An individual was inactive for a period of time and then picked it back up training, or they were injured for a period of time and then got back into training, and then they experienced this reactive tendinopathy, painful tendon issue. Now that might be very painful, but it's actually unlikely that there is risk of tissue failure. So that would be an example of where that individual might be a good candidate for a pain monitoring model. And we can reassure that athlete that this painful tendon issue, your tendon is still very strong. And if we manage loads appropriately, and we're going to use your pain, your subjective report of pain, as one of the key inputs to determine the appropriate load, we're going to be able to rehabilitate this, get you through this. Whereas at the other end of that tendon pathology continuum, we have the degenerative tendon. And that tendon is typically not painful. That's the tendon that's weakened, has experienced tissue damage, and it's typically not painful. And that's kind of a scary thought in my mind, at least, because those are the ones that are most likely to actually rupture, right? So when you hear about people who have an Achilles rupture or a quadriceps tendon rupture, those injuries are most often not painful leading up to that rupture. It was tissue damage that occurred previously, maybe hadn't been properly rehabilitated, or the healthy tissue around that degenerative tendon wasn't strengthened adequately to maintain and improve the strength of that tendon structure, and then ultimately it failed. So I think we can reassure our clients with tendon problems in a sense that if this is a painful tendon problem, that may actually be a good thing because your body's giving us clues that it needs attention. And I think Dan Pope defined pain as a body's cry for change or attention. And I
Yeah,
like
yeah.
that. I like that a lot.
Absolutely. There's another one where I can't remember I can't remember the analogy who said that analogy, but it's a little bit like a smoke alarm. You know, something's going off. You know that there's a fire somewhere, but at the minute you just need to listen to the fire alarm because there's some smoke there. One thing, and you kind of mentioned it at the start when we started talking about or started talking on this topic about when clients, when athletes go in and say, oh, I've got that high pain threshold, and everything that you've mentioned, everything that you've spoken about there, how much is that? Where does that come from? Do athletes have higher pain thresholds, and does that come down to something physical, in terms of their previous training, where they are in their career, if you like, depending on how old they are or how young they are, or is that more of a mindset thing? Would you say?
So I think in the truest sense, I think we misuse this term high pain threshold often. So I think in the truest sense, a pain threshold is when a stimulus or some sort of input is no longer perceived as, like a tickle, but now we're perceiving it as pain. It's
Yeah,
met that threshold, but now we're thinking about this now as this hurts.
yeah,
That's not how that athlete or that client is using that term. They are using that term in a sense of, I recognize that I have high intensity pain, but I don't let it affect me. I don't let it slow me down. And they're almost bragging in a sense that in the face of this high intensity pain, I'm not stopping. I don't tend to stop. And this is that individual in my mind that has that no pain, no gain mindset. And that can be a challenging individual to work with, um, because it's certainly not a no pain, no gain situation. A well controlled pain um, gain situation might be a better way of describing painful tendon rehabilitation. So I think when the athlete or the individual says that they have a high pain threshold, that is a warning sign to the coach, to the clinician, that athlete maybe isn't appreciating fully, or isn't, um, I suppose, isn't allowing that high intensity pain that they're experiencing to change what it is they're doing in a day in and day out basis.
yeah,
And I don't think that's really anything to brag about.
yeah, yeah,
Um, so you have that individual, and that can be very much a challenge. And I think education surrounding a pain monitoring model can be very helpful for that individual. Now, we don't want to scare the individual
mhm,
and put thoughts of tissue failure into their mind, where for the most part that's not a valid concern anyway for a painful tendon issue. But we may wish to explain that continually pushing through these high levels of pain may be indicating to us that the loading or the activities that you're doing in the face of this injury are far from optimal. Um, and there's certainly something to be said for sensitization. So pain is so complex. There's potential for pain that persists. Individuals who have pain that persists to experience something called central sensitization, having trouble with that word, central sensitization, essentially where that process of the processes that are occurring where the whatever the nociceptive input, the inputs from the tissue that are being interpreted as pain are being amplified over time. We're becoming more in tune to that input, and it becomes harder to shake the pain when we have sensitization occurring. So we don't want to scare the individual, but we want to explain that this isn't necessarily a good thing, that
yeah,
or a point of pride at this moment that you have a high pain threshold. You're here. Let's try to get on a program that best manages it.
yeah. And do you think that because I do think that trend of what's the phrase, no pain, no gain, or anything like that. And that kind of like the grind, just going through things, even when you're injured, or have like a niggle, is fading out because I just think it just doesn't work. You need to get those hours in to get better at your sport or your skill or whatever it may be. So just pushing through actually can sometimes mean more uh, more time on the sideline. And just referring it back to the definition of pain that you mentioned, is that where when you're working with a client with an athlete, where that definition of pain will change, and then all of a sudden it does become actual tissue damage, and that's when things need to change in terms of um the plan going forward, if that makes sense.
That's a really good point, Coach. So along that, if we go back to our example of tendons in disrepair, along that tendon pathology continuum, there is the potential for reactive tendinopathy. That's our painful tendon issue to turn into a degenerative tendon. So to make the transition from reactive to degenerative. And when we're making continuous loading errors over time and time again, there is the potential for reactive tendinopathy to transition into actual tissue damage, a weakened tendon to degenerative tendon. So again, not to scare the athlete or individual, but if we keep making the same training error, we're certainly not going to effectively rehabilitate the injury. And there is over time the potential of making matters worse. Now that's a long-term thing. If you push through pain, here and there, if you push through high level or high risk pain here and there, most likely nothing adverse is going to happen, but it's the individual that has that mindset that's what they're going to do, and they're going to continue to do it. But I agree with you. I think we're doing a good job of getting away from that, and we're empowering athletes to manage their pain. And there are a lot of things that athletes do these days to manage their pain. So, pain being a subjective experience, we can do things like foam rolling, the Theragun, the electrical stimulation units, the portable electrical stimulation units, all of these things to better control our pain and give us a little bit more ownership over that experience. So I do still like to encourage that athlete or that individual with that kind of hard-nosed mindset to take ownership of it and to try to troubleshoot and reduce the intensity of that pain into parameters that are acceptable, and then move forward.
Yeah, I think part of that is adding in a little bit of maybe independence to them as well, like what you mentioned about controlling their pain, and or sorry, do they feel in control of their pain, and just think, look, these are the things that you can add in. I know for me, when members and clients come into the gym and they've got niggles, well, depending on the severity of the injury, I'll always refer out. But equally, there's a list of things there that they can do, and sometimes, having that, like what I mentioned earlier about sort of the softer skills of coaching, is making them realize that I'm not expecting them to just keep pushing through, just trying to tolerate that pain, or one avenue that we can go down as well is changing the exercise or modifying the exercise all the time. But there's only so much that from whatever exercise they're using, there's only so much either side of that spectrum that you can go, like what you mentioned, to actually get that training stimulus from there. So I think that's a good point of thinking about what they can do, but then also realizing that we can see how much in control of the pain that they are. What are your when it does come to sort of the exercise selection, and we'll kind of carry on this train of thought, is how much variation would you have from the exercises that they're using? Because when we're talking about athletes, the training program that they're doing, and you mentioned it at the start about being a more of a longer distance or an endurance athlete, it's repetition. there's going to be a lot of things that you're doing. For myself, competing in powerlifting, it's the same movements all the time, and then that's where it can become, we can pick up injuries. So when we're looking at exercise variation, how does that impact pain if all of a sudden you do change that exercise? Because you know, depending on the athlete, they might think, "Oh, hang on, this is a different exercise to what I've done before." Is that going to cause more pain, or actually is it just making the athlete control that? I realize I spoke a lot there, but does that make sense?
Think that's an excellent segue, actually. So, a lot of times I believe the go-to is let's change up the exercise. You have pain with this exercise, let's change it up. And a good coach, a good personal trainer, a good clinician has a variety of exercises, exercise variations that maybe train a similar movement pattern or the same movement pattern, that train the same muscles, the same joints, but may put a little bit less load or stress on the injured area. And we may have a good reason to believe this exercise will be better tolerated by the athlete. And that's a great place to start as a coach, as a clinician, even as an athlete who's troubleshooting their own pain. But I think we run into trouble when we just avoid it altogether or grab an exercise variation that's so dissimilar that we're no longer really loading that area at all, because we recognize that there was a good reason to be training that movement pattern. There's a good reason to be training those muscles, to be training that joint, and there's a really good reason to load the injury site if we're dealing with, again, the example of a tendinopathy, a tendon problem. There's a really good reason to load that tendon because that's actually the stimulus for repair. So it's the actual loading that's going to rehabilitate the injury. So if we avoid it altogether, or pick an exercise variation that's too dissimilar, it may be doing us a disservice, even though that exercise may be well tolerated and maybe pain-free. And that's okay for a while, but ultimately we want to get back to a variation that at least begins to that process of loading the injured area. So I know we get stuck in our ways. We tend to get stuck in our ways as athletes, particularly barbell sports, right? You compete in three main lifts, and damn it, you're going to squat, you're going to deadlift, you're going to bench press, right? And one of those exercises becomes painful, too painful for you to tolerate, and maybe even got it checked out, and you're pretty confident that it's a a musculotendinous injury, low risk. But you just can't seem to find an exercise variation that allows you to work through an acceptable level of pain. In that case, I do think it is wise to change the exercise variation. So we know, for example, if we're dealing with a patellar tendinopathy issue with the quad tendon, if we can pick a squat type exercise that loads the quadriceps maybe just a little bit less, or puts a little bit less compression through that tendon, that may mean limiting the depth of the squat, or that may mean performing a squat variation with a more vertical shin position, so a squat to a box, rather than free squatting, or changing the position of the load in order to accomplish a more vertical shin position. That may make that squat movement pattern less painful. And while it may not load the squat in quite the same way that your competition squat, that may not load the tendon in the same way that your competition squat does, that may be an appropriate variation at this point in time. So variations on exercise are certainly not a bad thing. My understanding of the literature on this, I believe it was researcher out of Brazil, Cassiano, in 2022, did a systematic review. I think Brad Schoenfeld was involved in this. Identified 8 studies looking at exercise variations and their outcomes. And the results were kind of across the board. So it seems that too much variation or random variation applied too quickly will result in decreased adaptations. So maybe less muscle hypertrophy, lower strength gain, whereas variations applied less frequently may actually show some benefit. So again, there's conflicting evidence here, but variations in and of themselves aren't a bad thing. But variation is, when we look at that term, variation implies randomness.
Mhm.
But what you and I are talking about is something very prescribed, very intentional.
Yeah.
So if we're thinking about exercise variations, I think we should think about exercise variation as exercise periodization. And
Yeah.
you can periodize a rehab program, and you should. So you have patellar tendinopathy, a patellar tendon problem. We're not just going to switch your back squat out for a box squat and have you sit back to that box, and that's the exercise variation you use all the way up until the point of your next powerlifting meet. That's a mistake. Now, if we treat it like periodization, okay, right now, Coach Stevens' patellar tendon is flared up. He can't barbell back squat to full depth at this point without, 8 out of 10 pain. And that pain seems to be getting worse day by day. We need to change something. Well, let's try a high squatting to a higher box. So it's going to limit squat depth, but it's also going to encourage a more vertical shin position. That's going to load the quadriceps tendon less. And then we ask coach, how'd that feel? In the moment, I still felt it, but that's a 3 out of 10 for that set. And then the next morning, it's not hurting any worse. So we're monitoring in another time frame. And now squats to a box become an appropriate exercise in your training program for this period of time. But we're going to want to progress that back towards your competition squat or the squat you need to perform with at your next powerlifting meet. So we're planning the variations, and our next progression might be, well, let's flip the box, make it a little bit lower to at least get the depth you need to hit a competition squat.
Yeah.
We're still encouraging that, sitting back into it toward the box in a more vertical shin position. So it's still probably not loading the quadriceps tendon as much as your competition back squat, but we're working back to the variation that's going to be tested. So I think of it as periodizing the exercise variations, rather than just randomly applying them.
Yeah, absolutely. What was actually quite funny there is you kind of described how my training was maybe a year ago, a year and a bit ago. I was squatting down to a box and then monitoring pain from there. So yeah, I feel as though you'd watched me a year ago do that then. Yeah, I think absolutely. What I really liked what you mentioned there is periodization, because I think sometimes you know again, maybe a little bit of a tangent when we're talking about injuries and niggles and pains and training, but sometimes people can feel a little bit lost. How do I get back to where I was before? But actually, by having that periodization, that plan of at some point, this isn't the exercise that we do forever now. We need to get we need to get to this next point. When we're looking at that and the exercise variations and trying to have some method behind the madness, if you like, what's the categories in your head to try and filter that down, so we know, okay, so is it range of movement, is it load, what's kind of the process in your head to be able to manage that athlete's pain threshold, but also make sure that they're still getting a training stimulus to then be able to progress back to where they need to be.
So, so I like to take a movement pattern based approach in understanding training exercises and human movement. So, it's very common to see exercises broken down into, your squat pattern. Sometimes that's called like a lower extremity or lower body push pattern. Your hinge pattern, sometimes that's called the deadlift or lower body pull pattern. You have your upper extremity patterns, your upper body patterns, upper body horizontal pushing, upper body horizontal pulling, upper body vertical pulling, upper body vertical pushing. And I think those are the major 6. You could incorporate some, twisting or bending through the trunk or some core work if you wanted to consider that another resistance training movement pattern. But I kind of break it down into those major patterns and try to determine, okay, what movement pattern or patterns is the athlete having trouble with or having pain with? And usually it's pretty easy to guess that, for example, your injury you mentioned, if you have knee pain, most likely it's going to present during a squat pattern type movement. So we can draw from applied anatomy and our knowledge of applied biomechanics to try to predict what variation is going to be better tolerated based on the type of knee pain the individual has. So the individual has anterior knee pain right on the patellar tendon, right? It's not necessarily inside of the knee, but it's in the front of the knee. Feels like it's right on the tendon. So we can predict that something that applies more load to the quadriceps is likely going to be more challenging for that tissue. Something that applies a compressive load. So tendons are really great at handling end-to-end pull. It's when they get kind of pulled across a bone and compressed as they're getting pulled across a bone. That's when they tend to get pissed off a bit if they're already experiencing maybe a reactive tendinopathy or issue like that. So we know that the patellar tendon gets pulled across the front of the femur, the front of the knee, more so in a deep squat. And we know that when an individual performs a squat with heavier weight, for example, on the bar, it's probably going to load the quadriceps more. So it may be as simple as lowering the intensity. I won't discount that, but I do think exercise variation can and should play a role here. So you have in the back of your mind kind of this progression informed by applied biomechanics and anatomy of which exercise variations are likely to be less stressful or apply less load to that area of the body that's injured versus the ones that are likely to apply more load or more stress to that area of the body. And we can manipulate other variables of exercise prescription as well. We don't have to limit ourselves to just exercise variation. In fact, when we're dealing with musculoskeletal injury like a tendinopathy, the period of recovery in between training bouts should be considered. So let's make sure that we're not training it too frequently. So maybe spacing out our heavy squat days, making sure that the tendon has maybe at least 48 to 72 hours to recover from your heavy squat sessions at this stage. But I think laying that out for the client or athlete, these are the general exercise variations that I think you would benefit from. And then we're going to auto-regulate. And I think coaches are familiar with that term, but the client may not be familiar with that term, auto-regulation. We're basically going to take your input, maybe in the form of this pain monitoring model during the workout and maybe the next day, and use that as information to help us auto-regulate when it's time to increase the load, increase the weight on the bar, modify one of these other exercise programming variables, or switch to the next more challenging variation. So I never set out a calendar. This is when, like a strength coach might have an annual plan laid out, periodized for their athlete and team. And that's great for something that's a bit more predictable, like a season of sport. But no clinician or no coach is going to be able to predict how quickly that knee injury is going to resolve or begin to feel better. So I always like to leave the time frame a little bit more open, but I present a plan. And I think having that plan laid out, at least verbally, maybe even on paper, hey, if the individual is working more independently, you could give this to a client as a rehab template in a sense. This is how you're going to get back to performance. And I think that can be a powerful thing.
Absolutely. I think, I think you touched on it earlier on in the chat as well about giving the athlete actual knowledge. Why is it that they're doing that? Because then that way, when we're talking about control, when we're talking about bringing that that threshold or barrier down to be like, look, we don't need to push through it. All of a sudden, because I think as soon as something happens and then we get the ball rolling on trying to correct things or help them, I want to get back as soon as I can, because ultimately, whether it's people training in the gym, whether it's someone performing a sport, we all started because we enjoyed it, and everyone wants to get back to it because I think there's everything as though like I actually spoke about this the other week. The example was I knocked the bumper off my car, and I was thinking, oh no, that's it. I'm never going to be able to drive my car. I'm not going to be able to fix it. Whereas actually, finding out how to take the bumper off and put it back on I was like, oh, okay, that's actually pretty good. It was a quick fix, whereas in my head it's going to take longer. And I think sometimes when we're talking about injuries, if we think it's going to take 3 months and we commit to that process, then actually it might take a little bit. It might take a little bit less. It might take a little bit longer. But at least then you've got that thought process of actually it doesn't necessarily need to be as bad as what people think. Is that the response that you found from actually giving clients and athletes the knowledge, so that then that way they can control their pain threshold or control the exercises a little bit more, or maybe highlight things a little bit more to you sooner?
Yeah, so we're all searching for quick fixes. You wanted your bumper fixed immediately, I'm certain, and as would I. And it is our responsibility to give our clients, to give our athletes an indication of prognosis. How long do we think this is actually going to take? We can't give them an exact time frame, but we can give them a general idea.
Yeah.
And I think that does set the expectation. And usually that comes as a shock, because I want to feel better next week. I want to feel better tomorrow. But when I say this reactive tendinopathy may take multiple months, 3 or 4 months to fully resolve, boy, 3 or 4 months. I mean, I'm done with my season by then.
Yeah.
I have 2 meets planned in that time. But wait a minute. We're going to use the pain monitoring model, and we're going to use a progressive training program to get to that point. And you're going to be feeling better along the way. You might be getting stronger in a lot of ways along the way. And we're going to point out each and every one of those milestones that athlete meets. So they're going to know that they're making progress, and that's very motivating. And it helps that time that we know it takes time to rehabilitate injuries. It helps that time go by and keeps them motivated with the process. And I think barbell athletes such as yourself are maybe rare in this case, where you focus on certain exercises and a handful of variations, and you're content doing that season in and season out. With the majority of clients I see from the general population, it would be very difficult for a lot of my clients to commit to just squatting, deadlifting, and bench pressing as their primary fitness or resistance training exercises. So in a lot of cases, the idea of variations can be exciting for the client. And I believe it was a group of Spanish researchers, along with Dr. Schoenfeld, showed that exercise variations can actually increase motivation to train.
Mm-hmm.
So we can use this to our benefit, present an exercise that maybe the athlete hasn't done in a while. It hasn't been in your program in a while. And, I'm going to get to do Bulgarians. Oh man, they're going to hurt, but I haven't done those in a while. And I'm kind of excited to program those for the next 6 weeks or so. It's one of those things where we can use that intentional variation in the program as a strength, not a barrier to participation in the rehab exercise.
Yeah, absolutely. I think the variation side of things, speaking as a powerlifter, using a safety bar, even front squats. I can't say I've ever looked forward to doing Bulgarian split squats, but yeah, adding that in is something exciting, and I think that's why speaking about the exercises that athletes do, that mindset shift, if you like, can be, actually it gives me an opportunity to be able to do this or focus on this. One of the things that I've said before, lifters that I've worked with or do work with, okay, so we're going to be focusing on box squats. We can PB and bench press. We can focus on we can focus on this. So I think sometimes having that mindset shift, and the knowledge that we've spoken about ultimately helps the athlete and just arms them to be able to think, actually, we've got an actual plan, a little bit like what you mentioned about the periodization. We've got a focus to go on, and that's what I wanted to dive into today with you, because I think everyone knows about planning into a season, like an off season, or planning into a powerlifting meet. Whereas actually, when it comes to pain and we start going off that way a little bit, it doesn't have to be a case of let's just try this. There's got to be a thought process that we need to work through. quite a lot of topics and tangents thrown in there. But the last question that I like to ask Merrick, from everything that we've spoken about today, and for everyone listening, whether it be a lifter or an athlete who might have an injury or might be suffering pain, or the coaches listening, what would be your take-home points or words of wisdom from everything that we've spoken about today?
So pain isn't the end. And I believe your previous podcast guest, Dr. McGill, his book, The Gift of Injury, right? That resonates. We can use these difficult times, these injuries we experience, to ultimately make ourselves stronger, more knowledgeable athletes, more knowledgeable coaches, better clinicians. So in a sense, that pain can be thought of as a gift. Just like the degenerative tendon problems that are actually more likely, the pain-free tendons that are actually more likely to actually rupture than the painful tendons. That pain is a gift. It's your body saying it needs some change. And that change we've talked a lot about, on the biomechanics side, exercise selection, exercise variation. We've gone down that rabbit hole today in this conversation, but we can incorporate change in other areas of our lives as well. So pain is so complex. Injury is so complex that exercise variation and loading is only one piece of the puzzle. There are so many things that we can explore and learn more about as far as nutrition, sleep, that will ultimately make us better, stronger athletes and more productive humans in the long run when we come on the outside, on the other side of this injury or problem. It's so easy to get down, especially when we have a strong athletic identity. And I think pretty much all strength coaches have this. Most successful athletes have this. A lot of general population individuals actually have this to some extent. They like to go to the gym. They like to go to CrossFit. They like to be active. And it can be a big hit when something threatens that or takes that away or interferes with that. But I suppose the take-home message is it doesn't have to be a loss. It can be a net gain. As long as we're patient, stay the course, get the right help, obviously, but don't give up.
I think that's a really good take home point. One of the and I've maybe touched on it before, but my very first coach when I first started playing rugby was, you're going to learn a lot more from a loss than you are a win, and sometimes it can be a really good reflection to think, actually, how can I keep on top of this? And it might actually open up doors to, yeah, do you know what? I actually need to focus on my nutrition or my sleep or my stress or anything like that. And I think it can open doors to think, what is it that you need to focus on, which I think is an important topic to touch on, because I think it'll never be a thing of a past. When people get an injury, no one's ever going to think, okay, great, I can do this now. I don't think that'll ever happen. However, I think that's a human reaction to think, oh no, what's gone on? Like with me knocking my bumper off. But if you can actually, accept that, I think there's the 7 phases of denial or something like that. If you can do that and then move on and think, okay, how can I action this? I think a lot more athletes, a lot more clients will get back from injury, because on the flip side of it, which we maybe didn't touch on, sometimes you see people moving away from the sport or not wanting to do it anymore and commit to it, which hopefully, for everyone listening, they can see that there is actually a plan, and there is systems out there that can work. Thanks a lot, Merrick, for taking the time to jump on. Really, really enjoyed chatting with you today. If anyone has any questions about what we've spoken about today, want to see the content that you put out there, or reach out to you and ask you any questions, where could people find you or reach out to you?
Yeah, so I'm active on Instagram. So I have I guess a link tree or solo link in my bio that links to all of my fitness writing, some of my research publications, some of the other podcasts I've been on recently. And I'll be speaking at a National Strength and Conditioning Association conference in the States in April, Great Lakes Conference. So if you're local, come see me there, speaking on a related topic. But yeah, just reach out. Love to chat. Love talking shop. And thank you for having me, Coach.
No, no problem at all. Like I say, thanks a lot for taking the time to jump on. Thought there was some really, really good content in there, and a really, really good message. So, thanks a lot, Merrick, for taking the time to jump on. Thanks a lot to everyone listening, and I will see you all next week.